Parents, have you ever thought your child is out of control, abnormally destructive, or always moody? Well, there's a possibility that your child is not being intentional, but rather suffering from a mood disorder called disruptive mood dysregulation disorder. DMDD, as it's often called, is a new disorder developed by the American Psychological Association. DMDD is characterized by extreme tantrums that are not age-appropriate or appropriate to the trigger of the tantrum. DMDD is also characterized by constant irritable mood. The child is always angry or is seen as just a very unhappy child. Two more things are needed to be diagnosed with DMDD. A child must be 6 years of age, and these symptoms of irritability and extreme tantrums must be present for 12 months, so a full year of seeing symptoms.
Disruptive mood dysregulation disorder, or DMDD, often manifests in temper tantrums. These tantrums can occur several times a week to several times a day. It might seem that the child throws a temper tantrum anytime something goes a little bit wrong. These mood outbursts may look a lot like yelling, screaming, crying, or blubbering, kicking, hitting, throwing objects, or throwing oneself on the floor. Another big warning sign is that these tantrums often occur over small, silly things like losing a toy, dropping a snack on the floor, or accidentally tearing a picture. In between these tantrums, the child will generally seem to be in a bad mood, angry, or agitated. The main risk factor for DMDD is just a lack of positive affect. The child may react very strongly to negative social cues or events and tends to seek out or look for these negative stimuli. It is apparent that the child has difficulty understanding and processing their own emotions, and sometimes he or she may have difficulties processing the emotions of others. Another strong predictor of DMDD is being easily agitated or excited during infancy.
For an example of DMDD, let's examine the case of Sarah. Sarah is 8 years old and lives with her parents and younger sister. From the time she was a baby, her parents have noticed that Sarah rarely seems happy and is easily upset. Although Sarah loves her family, most of her interactions with them are stressful for everyone involved. Sarah is irritable most of the time and becomes very angry even with little provocation. For example, when her father asked her to clean up her plate from the dinner table, she began screaming, crying, and throwing the rest of her dinner on the floor. She continued sobbing even while following instructions to get ready for bed. Sarah throws tantrums like this at least 4 nights a week. Sarah succeeds academically despite having strained relationships with peers. Her teacher reports that she often interprets accidental bumps as shoves or neutral glances as glares, and usually seems on edge. Her parents are exhausted and upset by her constant negative mood.
Sometimes disruptive mood dysregulation disorder can look a lot like other disorders. Unlike oppositional defiant disorder, DMDD is not a problem with conduct but with mood regulation. The child will often obey directions from caregivers during tantrums and during the intervals between them, and may appear to be sorry or worried about the consequences for his or her behaviors. DMDD can occur alongside ADHD, but unlike DMDD, the behaviors in ADHD can include anything from throwing things to fidgeting in a seat to talking excessively, and are not always negative or upset as they are in DMDD. Bipolar disorder is another type of mood disorder where irritable mood occurs. However, in DMDD, irritable mood is consistent.
PCIT, or parent-child interaction therapy, can help build the relationship between the parent and the child. It helps parents to learn contingency management skills, and parent management training can help parents focus on good behavior. A second form of treatment is cognitive behavioral interventions, which focus on a child's chronic irritability. These interventions can help the child become more aware of his or her own emotions and those triggers, and the child can also learn calming and relaxation skills and strategies. And finally, family therapy focuses on both the parent and the child, and psychosocial treatment includes skills training for both parents and children in groups that meet simultaneously.